Hello, I'm Dr. Tasha Phillips-Wilson, incoming resident at University of Maryland Capital Region Health, and I have the esteemed honor today to sit with Dr. Eldrin Lewis, esteemed clinician scientist, internationally acclaimed advanced heart failure expert, professor and chair of the Division of Cardiovascular Medicine at Stanford University. Thank you, Dr. Lewis, for this opportunity.
Oh, you're very welcome, Dr. Phillips-Wilson. Thank you so much for inviting me.
So today I'd love to talk to you about the demonstration of excellence in the field of cardiology, which you've shown in numerous ways, including clinical care, advocacy and heart failure management, community partnership collaborations, clinical trial expertise, research and publications. So I'd love to chat about a few of those things with you today.
Oh, that'll be wonderful. Thank you.
Excellent. So we'll start with patients. Patients are the most important. This is why we go into this. So in your commitment to ensuring high quality cardiovascular care, what are some ways you've gone beyond the guideline-directed medical therapies to ensure superior patient-reported clinical outcomes for your heart failure patients?
Absolutely. So I think the first thing that you want to consider is making sure that you understand the needs of the patient. And part of that is understanding kind of what makes them tick. And you have to meet the patients where they are. So for some patients, they have a high medical literacy, health literacy. For some, they don't. Some are used to the medical establishment because they have other chronic conditions. And for others, this is the first step. This is a first foray, if you will, or the first experience with having any kind of insult onto their healthcare. And so when you're taking care of a patient, they want to get back to being people. So I often will ensure that they understand what are the ranges of therapies that we can offer, what is the why behind the therapies, because a lot of times we have to start patients who have no prior history of medical problems, and then they're on at least 4 medicines and sometimes 5 or 6 medicines just to manage their heart failure. So you can imagine the 5 stages of grief that patients go through from loss of health instead of a loss of a loved one. And we have to help them acknowledge their concerns, their fears, their anxiety, the fact that they're going to look to other sources to try to get data such as prognosis and expectations. So what I often would like to do is to establish that this is my goal, is to get you from point A to point B. I want to be realistic. Because if you have a patient in whom you don't feel that you can get them back to their pre-heart failure quality of life and their exercise capacity, I usually will say that. And I would say, I'm really concerned that your heart failure is quite severe and there's a possibility that we might need to do something such as transplant. But even when I'm dealing with a sick patient who I don't anticipate will have full recovery, I still want to give them that hope. So I will say these are the things that we're planning to do to try to mitigate that risk. And hopefully this is a bridge that we never need to cross. The other thing that I do is make sure that they can feel the care that I have. I often will say that why should a patient care about what you're saying if they don't feel that you care about them? So it's really important when I first meet a patient that I do understand at least 1 or 2 personal things about them so that make them unique. Yeah. For many patients, it's their children, it's their life story, their where they went, what kind of work they do, the hobbies that they have, but something. And very rarely will a patient say nothing. I don't do anything, there's nothing special. Most times they do. And I will follow up with that. The last thing that I do is try to, even for follow-up, I try to understand what are the things that are happening in their lives right now. So for instance, if a patient says, I've never traveled since I've had the diagnosis of heart failure and I'm excited about being able to travel for the first time, I'll say, okay, great. And I put that in my note. The next time I see them, I'll say, by the way, how was that trip? How did you tolerate it? You have to show me some pictures. Those are the little things that can actually show that you're spending more time than just getting them on the GDMT. Yeah.
Awesome. I love that element. You're adding in not only health education, but that element of empathy and humanism in medicine that we need for the patients to really trust us as physicians. With your numerous publications, over 200 peer-reviewed journals, including in the Journal of American College of Cardiology, as well as serving on numerous editorial boards, you have exuded expertise and excellence in this area. What are some tips that you can give to early career physicians in ways that they can set themselves apart, but also be impactful in the product with their manuscript writing?
Absolutely. I think the first step is to find a passion for something that you're going to do, the questions that you're going to answer. It doesn't matter if it's an important question. If it's not important to you, then it's going to be hard for you to really put the effort into it in order to be successful. I think the second is to make sure you have the right environment that's conducive for you to be able to do that research. And part of that environment is choosing the right mentor or mentors. That's probably the most important step after you understand what you want to do. Because that mentor will be able to really direct you with regards to what your what are the limitations, what are you going to be able to accomplish versus something that you'll have to wait until you're more developed in your research career to accomplish. You have to count the cost, and that includes the scope. Is this something that you can do by yourself, or do you need to have a team? And if so, who's going to be on the team, and how do you put that team together? And then the fourth thing is to really read. You have to understand what is out there. The worst thing is to spend 6 months doing an analysis and then you publish it and then the reviewer says, yes, we've known this for 4 years. There are 25 papers. How does this add to the literature? You should already do that in counting the cost. So you could say, here are the things that we know. These are the gaps, and then go from there. So when someone is just starting out, when you talk to your mentor, they can actually tell you, these are the questions that I'm interested in. But a good mentor will ask you, what are you interested in? Out of all of these questions, are there any questions that you really want to answer? And this is how we're going to do it. There are some databases that you can use. There are some limitations and risks with that. A lot of people will do retrospective analyses, and there are some limitations there. Sometimes doing a meta-analysis can actually be your gap analysis of the literature. So then you're putting the work in to understand what's out there, and then you're getting a publication out of it that counts as original research. So that's another thing, is to think about a meta-analysis and how is that going to add to our understanding and frame the question. The last thing is, if you're thinking about a question to kind of base your career development award on, like a K-23, et cetera, I always say, go to the guidelines and look at what's a 2A or 2B indication. The class 1s we always do. The class 3s we should never do. The class 2A and 2B means it's a little soft. We need to get more data. And so you can say, here's a small question that may change this from a 2A to a 1, or from a 2B to a 2A. I'll give you one example. Early in my career, we were looking at, there was a discrepancy about alcohol, and so we started just looking at an existing database about alcohol and looked at the subsequent risk of morbidity and mortality. We were able to answer a question that said, okay, well, now we understand a little more. Or even thinking about endpoint definitions. How do we better define heart failure? Do we need IV diuretics? What if they only got oral diuretics? What does that mean? And how do we calibrate the severity of illness? These are the types of things that you can do. And then the last thing is you can do quality improvement projects, because that'll be helpful for the division, for the department, and it's something that you can do in a short time frame.
There's a plethora of advice. I'm so grateful. Thank you for sharing with us. Now I'd like to transition to diversity and inclusion. And in a time of so much socio-political turbulence, this is very important, particular to the ACC, who is, very dedicated to transforming cardiovascular care for all. So what are some ways, like a physician who's clearly values the efforts of D&I, sees how it improves patient health outcomes, and someone who remains dedicated to the mission, how would you say that we move in these times to be supportive of each other, but also to be impactful still when, so many institutions are folding? What is your advice?
Absolutely. My first piece of advice is to be outstanding. Be outstanding. So when you're excellent and outstanding in what you do, it gives you latitude. When Oprah Winfrey started a talk show, she was outstanding. There had never been someone like her. And then she became the standard. And I think we can do this in the care that we deliver, the research that we do, and the questions that we ask. I think the second thing is we have to resist the temptation to be angry, fearful, upset, frustrated, because those are emotions that are not going to help you stay focused. And it creates stress unnecessarily. Stress, we know, whether it's good stress or bad stress, is bad on the system. But more importantly, it can have you questioning, what are you doing? Where do I fit? So know that you belong. It is really hard to become a resident, a fellow, an attending. Each person can make an individual difference. The third thing is to control what you can control. We can't control policies that are made on the federal or the world stage. We can't even control all of the things that happen at our institution. But what we can control is how we treat each other. To show empathy, to help people when they're having a bad time, and just to encourage them, pick them up and say, it's going to be fine. When someone visibly doesn't like you just because of who you are or who you love, doesn't mean that you have to resist the temptation to kind of escalate, because that's not going to change anything. But the antidote to hate is love. And the antidote to darkness is light. So you have to be that shining light. Now, practically, I think there are a lot of things that we can still do in terms of helping to reduce inequities, to improve diversity. And part of it is by being you, so that people can emulate you and say, you know what, I was nervous about going into medicine, but I see someone who looks like me, who came from the same background as me, and they're doing it. So tell them, and then you can share your story. And so as you're continuing to ascend, and this is for all trainees, you can always reach back and help someone who's in high school, who's in college, who's in medical school, residency, anywhere where you've already gone on that journey, because you can teach them what they need to do. And that's going to be one person at a time. Is it going to change the entire country? No. But for that one person, you've changed. And then that person can be the next light to pierce darkness. And then it continues on. And then finally, I think there are so many, it's the work that we have to do prior to just really within the decade was always kind of less than. It's not important science. Well, I'm going to take a step back. I do, in addition to large clinical trials, I do patient-reported outcomes, quality of life. When I first started out, people were like, it's not important and you can't measure it. And I said, quality of life is like the oxygen content in the air. No one worries about whether or not the oxygen content is acceptable until they can't breathe. And then all of a sudden it becomes maximally important. So no one cares about quality of life, saying it's not important until you've had a stroke, heart failure, myocardial infarction, peripheral arterial disease, and your life has been impacted. So I would say the same thing happens. When we think of diversity, it's often construed as a four-letter word and is often construed as less than. But let's imagine for a moment that we said for the rest of this year, every person in the United States has to decide what they're going to eat for breakfast, lunch, and dinner, and there can be no diversity. So if you choose a bagel, 365 days, if you don't eat a bagel, you'll eat nothing. If you choose a sandwich for lunch, that's going to be your sandwich for 365 days. Same thing for dinner. Imagine if we could choose only one movie to watch for the entire year. And forget about cable. All we need is one channel, because you only get one choice. You don't get like 500 channels. You don't get the diversity of saying game show today, sports tomorrow. And you can choose one sports. It's not basketball season, baseball season. No, you only can watch one sport. So what I'm getting at is diversity is relished in everything that we do. except when it comes to who we are. And those are the messages that we need to continue to say, there's a beauty in the fabric, in the tapestry of diversity. And we need to accept it, and we should not say this is not right, but we should connect those dots for people who don't understand the value of diversity.
Excellent. Thank you so much for those uplifting insights. And then lastly, Dr. Lewis, as we're talking about weaving into the fabric, ACC has weaved in health equity as we're trying to transform cardiovascular care for all. Partnering that with clinical trials and making clinical trials more equitable, what are some ways that we can move the line and improve clinical trials to make them more equitable?
Absolutely. So this is something that is near and dear to me as a clinical trialist. And the first thing we have to do is dispel the myths. So the myth is if we have diversity in trials, it's going to slow down the enrollment. So we say we can't do it. Then the second is we look and we can't find anybody. And the third myth is it's going to cost so much more. And the fourth myth, which we've published on, is, well, we don't want them in the study because people from diverse backgrounds aren't going to take their medicines. Meaning that I guess because of the color of my skin or my racial classification, I'm not going to take study drug. I'm going to mess up the study. And all of those myths have already been dispelled. We need to understand where patients are. I keep saying meet patients where they are. That's particularly important when it comes to clinical trials. Patients drive 4 or 5 hours. People have flown to see me, across the country. They followed me from Boston. However, if I'm doing a clinical trial but not getting care to try to get better, those same patients aren't going to say, I'm going to drive 4 hours for a clinical trial visit. So, excuse me. So we need to decide how can we better do the study procedures where the patients are. And that includes community participatory research, training people who are in the community, a trusted voice, to be a part of the research team. And they can't be modular. They have to actually be integrated into the care team, into the research team. And then the last thing that we have to do is to show the value of having this. There are so many times, the examples that I would give is we wouldn't have known about PCSK9 inhibitors if you didn't have African Americans, where the GWAS they did genetic polymorphisms showing this and showing this as a possible drug target that now helps everyone. We wouldn't know about angioedema in the setting of bradykinin if we didn't have African Americans who were enrolled in some of the trials that looked at ACE inhibitors. And so now we know that's a safety mechanism that you might not have seen if you didn't have a diverse patient population in the trials. And the biggest reason that we have to do it is because we want to match the demographics of the people that we serve. And when we're trying to go out, there are so many people right now that don't believe in science. But if we have people that look like them, that come from their environment, their community, whether you're in rural Appalachia, rural South, or in urban areas like New York City and San Francisco, if patients who look like you are in the trial and they're basically saying, I understand the value of this, then when we trying to transition from efficacy in the clinical trials, the phase 3 trials, to effectiveness, we now can say, this was represented by you. So I'll end with this. One of the things that we have not done as clinical trialists is we haven't given back the information to the people who participate. I'm a firm believer that at the end of the trial, we come and present at the ACC, and it's great. And it's great to be on the big stages of the late-breaking clinical trials. We need to do the equivalent academic detailing to the people who participated in a lay term to say, thank you so much for participating. This is what we've learned, and it's changed practice. That's going to go and motivate people to say, I need to get other people involved. That's how we do it.
I love that. Go back and share it with the community for which, you've built the information, the knowledge, and that's going to help build trust in the medical institutions and in providers.
That's
so
right.
Thank you for that insight.
You're welcome.
So thank you, Dr. Lewis, for joining us with Fits on the Go interviews. And for more videos like this, you can check out our channel at youtube.com/FitsOnTheGo.